thank you, everyone, for trying to help us piece this together amidst adversity. I guess that's probably a good message for us all, and I really appreciate that.
Yeah, I was very interested in your talk and actually your history, which was alluded to by one of the plenary speakers this morning who had worked with you. You probably remember the person who worked on was it Helicobacter?
Oh yes, Barry Marshall. Thank you.
Yeah, he was. That's good to know. And so, I mean, I've been my interest mainly is in immunology and biochemistry applied to infectious diseases recently. So, yeah, I mean, I was quite interested also in the social aspects, the societal aspects that you mentioned, which I will talk during, briefly introduce during my talk as well, because there are some implications there. So this has been the concept of malnutrition at very early age. Can you hear me?
Yes.
Yeah. Okay, the concept of malnutrition at an early age impacting on development has also been sort of quite well studied. And I don't know whether you have any comments on that. I mean, I listened to at various times people describing its impacts.
Well, since Dr. Scharf is right here, who's the real pediatrician and expert in this area, I will say that you're absolutely correct that the nutritional status of children in that first 2-year window is extraordinarily important. Even at birth, referring back to mom's prenatal experience, as well as what happens after a child is born into poverty and inadequate sanitation that they start imbibing. And so we've been interested in the height for age Z-score that drops most dramatically, even despite the initial birth weights, for example. It's what happens after birth that has been a focus of our interest in intestinal infections. But what happens before birth is also terribly important, as Dr. Scharf mentioned. So, Rebecca, you may want to comment to Dr. Ramasamy. Am I correct?
Ramasamy, yes.
It's fantastic. Thank you. Yes.
I agree. I think very important, both the prenatal effects from the mother. We can predict a lot actually based on what birth season a child was born. In our site in Tanzania, there's one harvest. So right before harvest, there's a lot of malnutrition. And I can predict a fair amount about that child's cognitive abilities years later based on what birth season they are born, which I think highlights the importance of nutrition.
And season of birth being perhaps reflecting both mother and child's subsequent postnatal experiences and exposures. Yeah, you may have had some other thoughts about that as well. I would love to hear yours.
Oh, I think I mean it makes intuitive sense. I'm not a physician. So my daughter has connections with pediatrics and infectious diseases. So I get a bit of input from her as well. But I heard this from many other people. And so just for your information, my daughter's shortly traveling to Rwanda to look at atypical salmonella vaccines based novel constructs using membrane liposomal constructs, as it were, which they hope will be quite effective. And she was, and you probably know Andrew Pollard and Oxford.
Yes.
He's
Uh,
been,
Where is he?
he's based in Oxford. He's
Yes,
head of the vaccine group, and he's also done a lot of work in Bangladesh, Nepal, and India.
of course. Yes, yes. A well-known group. That's where your daughter is?
Sorry?
Yeah.
Yeah, no, they're doing all sorts of things in the group.
Yeah.
And so that's very interesting.
I wonder if Dr. Scharf or Dr. Guerrant want to comment on this, but like the idea of, and I wonder if it needs to be quantified a little bit more, but I think there is some data that from the Great Leap Forward in China, which resulted in acute malnutrition for millions of people. And they've shown that prenatal or early life exposure to that famine is associated with increased risk of TB. So we are still seeing the infectious ramifications of that famine. And I wonder if that's been quantified more for other infections. I mean, TB is easier because it is a notifiable disease, but like I wonder if that's been explored further.
Well, I think Richard would be the best person to comment on that.
Well, actually, I was looking at Scharf because across the MAL-ED cohorts, she was emphasizing the importance of nutritional status and growth of the children as a profound marker, predictor, however you want to say it, of cognitive and other child development parameters.
Pranay, I'm interested in that though, because I know about the Dutch hunger famine and that they've looked at developmental outcomes and mental health outcomes. But the infectious risk, I think, is also fascinating. I don't know, are there studies from that famine as well about TB or other infections?
I think people have started digging into the epigenetics of it, but I think it's all very early right now. But I'll send you some of those papers. But I know there's a lot of interest in the nutrition TB working group to start thinking about that. And, you know, in India, we had the Great Bengal famine and so on. So I think, again, things to dig into.
And then the longer I live, the more impressed I am that some of the obvious questions really never got asked. And there's so much information about that Dutch hunger winter famine and the people and some other cohorts that have been, you know, horribly malnourished. And I'm not aware of any of those follow-up studies paying attention to, yeah, somebody here had TB, somebody else here, somebody in here and here. I'll bet there are data, and it would not totally surprise me if it has yet to be mined by someone like you. I would not assume that it is not possible. It may be. And I absolutely agree. The thing that I was especially fascinated by, Pranay, was the similarity of the increased susceptibility to an infectious agent, even in our, and especially in our controlled studies in the mice. That cryptosporidium, 100,000-fold increased severity or measurable, quantifiable cryptosporidial infections with the same identical aliquot, another aliquot of the same infectious dose. It was just so striking. And we were able to, in fact, define that it was primarily protein malnutrition, that we could reproduce that in the mice with protein deprivation alone. And furthermore, we were able to show that in the gut case, and wanted to ask you about the respiratory tract, because in the gut, it was very clear that the protein malnourished mice had a dramatic delay in the shedding of infected or just shedding of their epithelial cells that normally renew, and a dramatically impaired multiplication or renewal of those cells. If the same is true in the respiratory tract, I'll bet it is, then that may even provide a potential mechanistic explanation for that other side of the vicious cycle, malnutrition predisposing to TB or enteric or who knows what other infections, with a potential mechanism by which that occurs. Because with Cryptosporidium, shedding that infected mucosa is the only effective host defense, is a major host defense, at getting rid of the infected epithelium, because the infection doesn't get internalized even into the cells, and they have to basically be shed in order to basically get rid of the infection. And that probably accounts for most of that 100,000-fold increase in peak infection severity. And I wonder if something like that with TB would be very similar.
I think Scott may have something to say about it too, but at least my reading of the literature so far and some of the work we've done around IGRA conversions in household contacts of persons with TB actually has not shown that persons with the unnourished people had a high risk of getting infected. And it looks like the risk is much greater in terms of progression. The risk of progression seems to be much higher in malnourished people. So they're not able to contain the TB in granulomas, and there's progression pretty soon after.
Not so much ability, but progression thereafter, which, I mean, what percentage of the world's population has had their IGRA or PPD converted? I'm among them.
Yeah. I wonder if it's got to do with the infectivity of the pathogen too. If the TB is just so infectious that it's just really, you know, that whatever difference that malnutrition makes, or that whatever protection that being well nourished makes is not sufficient to protect you properly from TB under difficult circumstances.
Interesting. Cryptosporidium may be similar in that regard as well, in that as few as 1 to 10 organisms can get you from some of the back calculations from the outbreaks and from some of the volunteer studies. And so, you know, just testing a few fecal coliforms in a bucket is totally inadequate to pick out the one Cryptosporidium in the glass that you just drank. So, yeah, and biomarkers of fecal contamination is another little side hobby that if you ever want to pursue that and get rich by marketing it, I'll send it to you. Anyway, it's yeah.
I sort of extrapolate a little bit, and you know, this is really out of my area, but I mean, we've had lots of suppositions in chronic illnesses of other types, blood chronic illnesses like malaria. Even you go on to talk about even gut infections like ascaris and pinworms do cause, and they're fairly common. Do they cause a degree of malnutrition? Very, you know, varying degrees of some sort of malnutrition, I'm sure. It would be my guess. But it's not my guess.
No, no.
Yeah. These in countries where this is common, we certainly might expect some consequences to long-term health. So,
back in the first half of my career, I realized that oral rehydration solved that dehydration problem. I worried that we needed something that would solve that HAZDROP, the malnutrition problem. And there are some interesting ideas, especially with respect to the protein story. We stored glutamine and alanine glutamine for a number of years. Now there are people that count that as an antioxidant as well. We heard yesterday. But I think that considering critical, whether it's plumpy nut or whether it's simple or whether it's tricky, are absolutely important to start defining. I think that's where Pranay is with his extraordinary TB story. And, you know, what's the best approach to get this, was it 80–90% benefit in outcomes, which is puts vaccines even as great as they are, and most other interventions.
I was actually going to comment on William Stork on the Th2 response in COVID-19. And that seems to be a little bit, you know, a little bit speculative. Is it something that is more common when you have airway infections, so infections going into the lungs?
I have been intrigued by Bill Petrie's IL-13 and Th2 story as well. And I would guess, Bill's not here, so we'll wave our hands, say anything. But I would guess that the link that he has been able to make to the hyaluronic acid production,
Right.
I suppose is a problem in asthmatics and in people with excessive Th2 disease responses, might well fit exactly what you're suggesting, that it might apply to other pulmonary infections. It's actually, it was a question I wanted to ask Bill, is what about pneumonia? You know, pneumococcal pneumonia, bacterial pneumonia. Bill's probably looked at stuff like that. He would think about it before I would, but it's something that we'll have to take to him to ask.
People are thinking of sort of nasally delivered vaccines against COVID. You know, something somewhat akin to the nasal flu vaccine. And you know, it's parallel to some extent. But one wonders about the you want to keep the vaccine as uncomplicated as possible because of possible airway hypersensitivity reactions.
Yeah, I know Bill has looked a lot at immunizations and is a real spokesperson in this community for clarification about the pros and cons, and the pros and the cons of not getting vaccinated, and the pros of getting vaccinated with everything that you can as soon as you can, especially if there's any immunocompromise. So I am not aware of any IL-13 problems with the vaccines, nor would I expect there is any, because we would know that from all the people who've gotten COVID despite their vaccines having been up to date. So some have gotten it and they've not fared worse ever, to my knowledge, in terms of any population study. Pranay, do you know more recent data on that? I'll bet you do.
No, I don't think so. That's a really fascinating endeavor to figure that out. Certainly would make it. But the question would be, if it's a nasal vaccine, would it have to, would it require like a cold chain? Because in terms of deployment in sort of the global south settings, like if it's a live attenuated virus kind of thing, then I think that might make it harder. But actually, I was going to tug on that Th2 thread a little bit more. Actually, do we have time before I do that? Just want to make sure we're sticking to the schedule. And it looks like, yes, we have time until about 3:45. So we could take a break before that, though.
Don't worry.
Um,
You have to.
On sort of the parasitic infections, so we were recently sort of trying to put together a conceptual framework of how parasites affect TB. And of course, we think there's a very direct impact, direct pathway through nutrition, which, really following on your work. But then the impact of it on the immune system, I think, is a fascinating one. And one of that is the Th2 response. And one criticism we got of our framework was we said, well, deworming would really help. But then the concern was, what about schistosoma and all the eggs it leaves in the liver and gallbladder? In your experience, knowledge of it, do you know that Th2 response remains durable, like that Th2 switch remains durable? Because I don't think the antihelminthics would eliminate the eggs. And so so basically then would like a schistosoma infection, even though treated, would leave you vulnerable to TB for life?
Well, that's certainly an excellent and answerable question, Pranay. Again, you're coming up with great questions that simply need to be asked. Or you need to find out who has asked them, but not always have they been asked. I do know that if you're concerned about endemic schisto, as opposed to the albendazole single dose antihelminthic and anti-gut helminthic treatment from mass treatment, praziquantel is also almost as easy for the flukes like schisto, and is good for most, but not all of the flukes, as you probably know better than I. But to be easy to, just take care of schisto to stop it from progressing.
Mm-hmm.
You're right. Pulling out all of those antigenic ova out of the liver is not something that's going to happen easily. So I don't know, though, the Th2 response is to not answer your real question.
No, but that's great that it's not a clear answer, and might be something worth asking again, like a infectious complication of an early parasitic infection. It gives us more. I think it gives more ammo in terms of high TB burden settings to sort of really acting on schisto and preventing it through behavioral as well as sort of routine treatments.
My dear colleague, Jennifer Downs, I don't know if you would have come across her yet. She's at Cornell and but lives in Oxford, but she does study schisto in Tanzania. We'll have to with you. She's done a lot of work there.
That'd be cool, like little question to ask. Because TB is notifiable, I think you can figure out, you can go back to a schisto cohort and figure out if they have TB.
Yeah, she may have that. She's in Wanza, but we can.